which will also take care of the technology which will be coming into the healthcare sector every second. What do I mean by asset light? Have people participating with you, have investors participating with you who are ready to fund for your capacity building, fund for your capex. I'm like, for example, there are a lot of MRI machines. Now this, I'm not from the medical field, so I'm totally different. Now, I'm told MRI machine also have certain technologies changing every 1 year or 2 years or 3 years. Why is the hospital, why is the doctor who is owning the hospital, Manoj, taking the risk? Why not you bring in a leasing company? Why not you have a lease model done where the risk is transferred? That's point number one. Second, there are certain Government of India schemes which has come up, which is a totally unsecured funds which even the government is giving for you to upgrade your hospitals. That scheme is, I'm sure a lot of people are not aware about it or they have not utilized it. Third is, there are a lot of subsidies coming up on the heavy equipment which you are buying, for example, the generators for this. People have not taken those subsidies. So these are the points that I would like to highlight is, I will not say that it cannot be done. It has to be planned and approached in that manner. If you allow me, I can just put one point. While we are talking of preventions, India is going to be badly hit with cancer. Preventiveness, man. How many cancer hospitals or Manoj, sir, please tell me, how many oncologists do we have, ma'am? What is the remedy? Ma'am, I am told, and this is a case study, Manoj. A doctor does not give more than 2 minutes for a chemotherapy planning because he has a lot of patients standing. He has to rely on technology. We don't have that many oncologists, ma'am. There comes the equipment, there comes the technology, but it comes with the costs.
So, just about capital is something we need to look at because the money can come in, but human capital, like you said, the doctors as well. One of the other paradoxes is, at least for charitable hospitals, the other hospitals, okay, they have their revenue models. For the charitable hospitals, there may be a lot of people coming forward to fund equipment, but you need to get the people also. So that's a very important part of the whole scenario, right?
People going to work in those charitable.
Yeah, and the other things where a lot of charitable organizations, including for education, suffer is the operating costs. There could be people funding infrastructure, but what about the operating costs? It doesn't fit into the CSR budgets of companies. So that's where in our financial risk, we always say.
What do you think is the solution? Most of even when we speak to a lot of people, everybody is ready for capex. I guess the larger corporate CSR is ready for capex. But when you say, okay, we want to fund OPEX, they all say, no, we don't have. 95% should go for capex. Maybe if you want, we can give you 5%.
In business language, a company will fail not because of losses also, but because of liquidity. Without cash flows, a company loses. I think that's where that hits even charitable hospitals, educational institutions.
I think Spurs is quite successful in terms of raising. You said today's almost.
I would say that people are not giving for OPEX. They are giving, but for specific purpose, like home care. Like inpatient care, they are not giving. Home care, they are giving for. And some other organization was funding for pediatric palliative. So some specific things there. No, just I wanted to add about asset heaviness, what you said. So while, for example, an MRI machine costs about 5 crores or something. Now, each hospital in India wants to have an MRI machine. Now, why do you want to have a machine? Why can't 3 hospitals together share one machine? Strictly, and if you have an MRI machine, unless you do about 20 MRIs a day, it doesn't work out in realizing your cost on investment. Now, each hospital, once you buy it, there's a pressure among everyone to refer cases for MRI because you need to have that 20 cases because you have invested a lot of money. So, this kind of sharing if you can have of expensive equipment, what is not required in minutes, but like MRI can be in a third party place and 3 or 4 hospitals together share.
You want a modernization of those models.
this will make it very asset-light for most hospitals. Already the leasing model is there, but even with that, there is a certain number they want guaranteed.
Some companies are asking for guarantees, some are not, because the companies that I work with, the family offices I work with, or the funds that we are managing, which is also coming from Japan, does not ask for numbers, but they say yes, your cash flow should be positive, because at the end of the day, they want returns out of it. And Manoj, you come from Mumbai, right? Let me tell you, sir, in Mumbai there is, cancer hospital is there in Mumbai. However, Dr. Chauhan has made an excellent cancer hospital in Kolhapur. As you rightly said, capacity building. Doctors are unavailable there in Kolhapur. And it's a state-of-the-art hospital that he has made, and Dr. Chauhan's protocols are even taught in US. But my point is, people are not reaching there on those corners. That is also a reason of making, as sir said, area more better, so that doctors come and say that, okay, I'm going to stay here, I'm going to enjoy here, there's a mall here. So again, you need funds to develop that also.
So, Ravi, what are the government policies specifically in the Tier 2, Tier 3, or Tier 4, Tier 5, in terms of building the infrastructure, especially like critical care or healthcare facilities?
See, it is not the central government, it is the state government which is having certain amounts allocated for development purpose. When I say development purpose, is certain subsidies. I don't recall the exact, because there are multiple subsidies in healthcare sector which is available. But the important point what Manoj I am telling you is, if a hospital operates in a Tier 3, Tier 4, Tier 5 cities, the benefit that it gets from a perspective of subsidy is higher than it is operating in a Mumbai, or for that matter in a Delhi, or for that matter this. But my point is, we cannot alone depend on the government to come in and do the entire planning for you and then make you a Tier 4 ready. It has to be a blended model of a public and a private model together.
So political will is very much needed, sir. In this, even for a private player to come in, political will is also needed for the partnership to happen. I think that's something we should take.
So I think, if we have to just take one lever, whether it's a funding issue, policy issue, technology issue, healthcare entrepreneurship issue, what do you feel?
Personally, I feel the policy of government to blend with private is not uniform, and it is very individual dependent. So if that is consistent, we can do a lot more work together.
Okay, so we come to the last rapid fire round. So what is that one big idea must act on before 2030 to ensure equitable health infrastructure by 2047 to become a resilient India?
Very good question. I think we should revive. If you remember 2 years ago, during there was a call for a health census again, which has not happened. My point is, India is again studying. The study is already on for a health census, which will actually tell us what is the status of each. It will be like a health Aadhaar.
Okay.
And I feel that census is the first step towards India to come towards that. Because as of now, whatever we are doing is a rapid study. We need a concrete health census.
So I think infrastructure is going well, so I wouldn't say infrastructure, but the thought process, preventive medicine has pointed it out. We have lost the concept of a primary care physician in India. Everyone runs to a gastroenterologist or a neurologist or a neurosurgeon directly. You have a headache, you run to a neurologist. You don't go to your primary care physician. So there's no one putting all your records together, which is very sad, and a lot of times very significant illnesses are missed. So, and a patient, when he goes to somebody, he takes this many files, and the doctor may not have the time to see. So there should be some way of unifying and having a primary care physician. This is a government policy. It has to happen.
It all comes to data, right? We cited census, you cited health data.
Yeah, I will also speak of data, because even to make it tech enabled, you need data first. I think every region is prone to different kinds of diseases. So I think we should have a risk priority number for it. Like in businesses, we do a risk framework. To get a risk priority number based on severity, we can do this. But a partnership can really help. That's where I think public-private partnership or now, as he said, provisioning partnership. Yeah, that is something which could really help in this. I think the principles which apply to financial models can also apply here. The risk assessment framework would really help, even in preventive medicine. I think we could really take specific steps which are suitable to a particular region, so that we bring down the incidence of diseases, so the infrastructure can cope with it. So I think that will make it more prepared for real occurrences.
All right, thank you so much, panelists, for your insights. And I think, this basically the CPR and Mission IC have come together for this dialogue where we are looking at, how do we build the, healthcare infrastructure, mainly in the rural India, so that what we faced during the pandemic, how do we become more resilient India. And I think, though we started as a COVID initiative, but then we thought that it is more about the inequity that we see, between the rural and the urban, that we are trying to help. And basically, what we feel is that healthcare should not be defined by the PIN code, right? It is more about how do we create an inequity in this healthcare system that it doesn't matter where you live in, anywhere in the India, but you get the same, healthcare benefits or, healthcare infrastructure. So thank you, everybody.
And just to add on to that, Manoj, a very good statistics I'll give as a closing statement, ladies and gentlemen. I was with the British healthcare system, which said, in India, your turnaround time of a doctor attending is better than UK. Although UK has a health card. So I think...
It's better than the US also.
So I think a round of applause to the doctors.
My daughter
Thank you. And I loved it because it was coming from the other side, and we always wanted to hear good from them. Thank you.
Two observations and one question. So in our journey of, I'm a co-founder of CPR. So in our journey of talking to CSRs, the point that Aparna made is they all want to do work in and around their locations, which all are urban. Right? It is important. The SBI, the Kotak Mahindras, the big folks who have enough distribution, they don't care. But when we start talking to really corporations, IT corporations, and so on, they want the geography to be local. So if you think rural, that's not there. The second thing we found is healthcare is still not a big priority. Right? They talk more about skilling, women's education, schooling, and so on. So those are two comments. But my question, or maybe we can talk later, is how do we all promote that so that they don't think about just urban areas, because they want their employees to be engaged, and there's no way to go even 50 kilometers away to be engaged. So that's a problem. We probably talked about 50 CSRs and about 8 are funded, but we constantly see the problem about where they want the assets to be put. So I don't know if you have any thoughts of how we promote that, the corporation saying that they should be going to the rural areas and so on.
Sir, as I would say, it is not a question of promoting whether you're going to a rural area or not. You have to talk on, you are developing that area. Sir, India is no more a country where you're just talking about 10 cities or 12 cities. India has got 8,950 cities. But today, if I can say, even a Bundelkhand is on the KRA list of upliftment of hospitals and good measures so that the healthcare rises. Sir, in India, I'm sure that I'm not a person who's from a medical fraternity, but let me tell you, government of India is working very seriously on sickle cell anemia centers, which means it is a priority. I'm sitting here, I'm talking about oncology, I'm talking about the chemotherapy treatment, which means somebody behind is also doing a research, doing a study. And this data does not come in saying that only the 7 cities is affected by it. When I told about Kolhapur or when I'm talking about Bathinda, they're the cancer capitals. When I'm talking of certain segments in Telangana or in Andhra, sir, Andhra is coming up with a very big JV. I'm telling you now, I cannot disclose the name, where a very big MNC is coming and setting up a hospital come medical college in a tier 3 city.
Okay, thank you.
All right, thank you so much.
Thank you everyone for this wonderful panel. May I request Manoj to hand over a little token of appreciation, please. It's not done until the picture is taken. Thank you very much, Manoj, and thank you to the panelists. We will now go on to the next panel, which is the clinical perspective on building a pandemic-resistant India. For this, I'd like to invite the moderator, Dr. Satya. I think he will join us in a few minutes. But let me call upon Dr. Clinician and a clinician with many years of experience, and now manages the operation at my Nationl hospital in Pune. Please welcome Dr. Supriya. Dr. M. Venkateshwarlu. Dr. M. Venkateshwarlu is also a pediatrician associated with Rangaraya Medical College. If Dr. Venkateshwarlu can join us.
I'll go and get it.
Okay. And he is very active in clinical practice in the Eastern Godavari region. Dr. Nitin Jain. Dr. Nitin Jain is the Managing Director of Ujjwal Health and has extensive experience in healthcare and digital health delivery, setting up these telehealth initiatives. Welcome, Dr. Nitin. So just give a couple of minutes to call upon our other panelists and the moderator. Please. So while we are waiting for our panelists, maybe we can touch upon some of the interesting pieces that I heard today and summarize the panel discussion that we had just now. I think the morning the call to action for all of us to work together was repeated by multiple people, and I really like the discussion around partnership for public provisioning, which Dr. Madan Gopal shared with all of us, and I think that's a real incentive for all us, for us at Mission ICU and CPR Global as well. So Dr. Satya is here, our moderator for this session, and Dr. Venkateshwarlu, please welcome. Please join us on stage. Over to you.
Good afternoon. Thanks for joining this simple perspective group. A lot of topics have been covered. My practice a cardiac electrophysiologist, so completely involved in critical care. And we've been very fortunate actually that we have partnered with two hospitals. One happens to be a government hospital, that happens to be a totally charity hospital, and I understand that you run your own private hospital. Am I saying that right? Yes. So, wanted to start this session by asking how this equipment infrastructure has helped each of the institution, and provide a few words from you. Please introduce yourself.
Myself, I'm Dr. Venkateshwar, gynecologist and pediatrician working at Government Medical College, Rangara Medical College, Andhra Pradesh.
I'm Dr. Nitin Jain. I'm heading a critical care unit in a corporate hospital in Delhi, and I'm running my telemedicine critical care venture.
I am Dr. Supriya Kurnikar. I'm a pediatrician by training, currently medical director of Mai Mangeshkar Hospital, which is a hospital which belongs to a public charitable trust.
I'm here with my HOD, Dr. Manikiyamma Madam, this time, because of whose excellence my unit is doing extremely well.
So one of the first questions I had was, the challenges we have seen apart from giving infrastructure to hospitals and all. How are you able to sustain? So I wanted to ask you, Supriya, about how are you able to sustain, actually expand on what you have done?
Yeah, so when CPR helped us through ASL, we were a 50-bedded small hospital running in 13,000 square feet of space. And we managed to get some buildings on site also. And today we have expanded to 200 beds. Initially we had an ICU capacity of 9, where we were helped with the equipment. Now we have expanded to 31 beds out of 200, which can give critical care. It was the help that we received through various sources, including CPR, for our equipment, which put us in a very good position to give a lot of care to the community. And then we could, I heard with great interest the initial panel where, I am a medical doctor, not very fluent in finance, but I heard about CapEx and OpEx, and giving equipment to us took care of, looks like the CapEx, and being a public charitable trust, we are very good in managing our OpEx. So we can sustain our hospitals well from the point of view of manpower and funding and etc. For equipment if we receive a little bit of help in the CapEx. So when we were helped for our 9-bedded ICU, we grew and we developed the capacity to expand into a 200-bedded hospital.
Another question I had, Dr. Jain, you are a critical care expert. Can you kindly comment on some of the bottlenecks like remote monitoring, and how are you able to cope up with tele-hops and all? Can you kindly comment on this?
So what I believe is that any healthcare is, I will say, not only about the infrastructure. There are two more components to it. Number two is systems, and number 3 people. In fact, if all 3 of them come together, then it really becomes a good healthcare machinery. So I will say, I've worked with hospitals who have got good infrastructure, they have got ventilators, they have got monitors. But unfortunately, the people there are not very well trained, and that actually has been a real gap in our healthcare systems. As I think our previous panelists discussed, our Indian healthcare system is more of super specialist driven. So I will say a nephrologist does not know how to treat an infection, but when a patient lands up in ICU, it is actually a multi-organ dysfunction. So that is where I will say the need for skilling lies. You need people who actually know to handle the patient in and out from top to bottom. Unlike a single organ where your focus actually does not move out from a single organ.
We are running a 150-bedded NSU setup. I'll tell you a small story. In 2014, Coromandel company people have come to our hospital to donate 65 lakhs to all the departments equally. But they come to our unit and they observe the quality and amount of work that is going on in our unit. They have donated all the 65 lakhs to our department. That has become the initiative point for the development of the department, where we are able to purchase ventilators, warmers, photography units, etc. After that incident, Dr. Sacha Garmadagar has taken all the interest and examined our unit. He took 19 long months to observe, to promote the donors, and at last we got 2 Dagger ventilators, which are high-end ventilators manufactured in Japan. These 2 ventilators were especially used for the preterm BLBW babies. The outcome is extremely good. Earlier, it used to be our preterm BLBW survival was around 70%. Now, the survival rate has become more than 90%. Sometimes, in a given individual month, not even a single death is being reported. This is a great achievement for a government institute. And they are kind enough to provide a whole body therapeutic hypothermia unit. So this is the one which is used for the hypoxic ischemic encephalopathy babies. Those babies who have experienced birth asphyxia, those who are prone for serious developmental sequelae in the future. They have given this equipment for us in 2024 August. Since then, we have kept this, we have used this for close to 20 babies. After treating, 16 babies are doing very well without any neurological sequelae. This will be confirmed by the MRI. All these 16 babies, MRI is normal, and they are doing neurologically normal. Sequelae, no sequelae. And this is a great achievement once again for us, for a government unit. So we are extremely happy with that, sir. And one more, they have given monitors also, Philips monitors, which are high-end monitors, and bedside ultrasound machine. We are able to see, for us, bedside echo machine, bedside ultrasound is a dream for a government institute. But we are able to do the bedside ultrasound and echo day in and day out. This is useful for the babies and for the residents also, post-graduates, DM students. Both ways this is useful. We are getting very good training. So with this, we are able to identify the early shock and able to screen the lung conditions, cardiac conditions, NSGs, early intolerance of the fluids, preventing NAC. Even before the X-ray could diagnose the early fluid intolerance in the form of necrotizing enterocolitis. So we are able to diagnose all these things very in advance, and we are using this equipment very well. It's of great use, especially for our unit. And the morbidity has come down very much, and mortality has also come down. Laminar flow system is also there. We are mixing all the fluids under the laminar flow system. The sepsis rate has come down. So as a whole, our unit mortality has come down. The extreme preterm babies survival has increased from 70 to 90%, especially with the usage of this Dagger ventilator. And therapeutic hypothermia, we are able to prevent the sequelae of hypoxic ischemic encephalopathy babies. 16 babies are doing really good. Otherwise, they would have landed in some sort of neurological sequelae. Say, a person who is eligible to crack the NEET entrance is not able to crack the NEET entrance because his IQ is lagging, say, by about 5%, and he's becoming a paramedic. A person who deserves to become a doctor, becoming a paramedic, just because of lack of proper care or the not able to receive the recent technology like in the form of therapeutic hypothermia. So he's given a full potential of brilliance. Whatever the God has blessed him with, he should live with this sort of this level of IQ. If he is falling down from that IQ just because he has some neurological insult during the birth process, and now we are able to give him the full potential, he is able to live with the full potential. What more you want? God has given the potential and we are able to recoup it. So we are doing wonderful job. That's all because of God's grace and the equipment that is being provided by the donors like you, sir. Thanks a lot.
Thank you. So one of the important topic which we have heard everywhere, like where the hospital I work, because I do